Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar. This evening, we're going to be talking about a multidisciplinary guided algorithm for the prevention and management of acute radiation dermatitis in cancer patients. Our speakers this evening are Dr. Alice Ho. Dr. Ho is a radiation oncologist, co-director of the Breast Clinical Research Unit, Department of Radiation Oncology at Duke University in Durham, North Carolina. We also have a speaker, Dr. Jonathan Leventhal, who is dermatologist, director oncodermatology program at Smilow Cancer Hospital, associate professor, Yale School of Medicine in New Haven, Connecticut. We would like to thank our supporter, La Roche-Posay Laboratoire Dermatologique, for making this educational event possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit the question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up. If you could fill it in and send it back to us, we'd truly appreciate it. And also within 1 to 2 days of the webinar, the recording and a certificate of attendance will be sent to you. Again, if you have any questions for our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Mr. Tyler Steele. Mr. Steele is Vice President and Medical and Media Relations for La Roche-Posay.
All right, folks, thanks so much for joining us this evening. Today's talk is based off of a publication that these two doctors, as well as several others who have been scientific advisors for La Roche-Posay, created. If you're not familiar with the La Roche-Posay, you may be wondering, why this brand? What do they have to say in this particular space? Well, La Roche-Posay is an actual place in the town of France, and they have been treating patients with balneotherapy or water-based treatments for over 100 years. The indications are often used actually for rheumatoid arthritis, but the unique water concentration in the town of La Roche-Posay is actually very beneficial for also cancer patients, plaque psoriasis, atopic dermatitis. The largest patient base is actually folks that have come post-cancer, and in France, it can actually be written as a prescription, so it's covered by French national insurance. This image you're looking at here is our first treatment center, which today is now used for our integrative health center. They also have corrective wig styling and makeup workshops for people that have gone through cancer. They have a special swimsuit section for people who want to use the gym facilities or in pool across the street. And these swimsuits are especially designed to have inserts for people that have gone through mastectomies. The center is now much larger. It can treat up to 8,000 patients a year, and folks come for 3 weeks of treatment. As I mentioned, the water is what's at the core of the treatment. It has been studied extensively and shown to be therapeutic and beneficial. You can actually also drink the water, and depending on your indication and what your healthcare provider there, your dermatologist there are 8 on staff, recommends you may drink between a half a liter and a full liter per day. The water is used in all of our products and is tested 1,000 times a year for purity and pH. And here's just a quick graph. As I mentioned, we do treat at the center atopic derm, psoriasis, children for all indications, and of course, post-cancer is now the largest indication. As I mentioned, that La Roche-Posay thermal spring water is at the core of all the products. And what you can see here is just a chart of other thermal waters as well as deionized water, which is standard water used in most skincare products. What you can see here is the water in La Roche-Posay, which has that very unique fingerprint, if you will, of bacteria, as well as strontium, selenium, bicarbonates, and other things that can only be found in the water there. It has a slightly acidic pH. And as I mentioned, we test the product extensively throughout the year to maintain purity and pH. As I mentioned, the publications, which are all peer-reviewed, have been featured throughout the year, showing a lot of indications for anti-inflammatory, sorry, I haven't had enough coffee today. Immunomodulation, antioxidant, anti-itching, which of course is great for those atopic dermatitis patients, or really anyone going through skin itch. Obviously, for anyone that knows, skin itch can be one of the worst things to deal with. Here are just some visuals of what the treatments look like. You can see the filiform showers, which are high pressure showers used to help drive the water into the skin. There are also soothing baths. And on the lower left-hand side rather, is a photo of a dermatologist using an oral irrigation device. And that's actually used on cancer patients who have gum sores due to various cancer treatments. So it just helps speed up the healing in the mouth. As I mentioned, the quality of life workshops are intended after therapy to help people just feel better about themselves. Obviously, cancer can change the way we feel. It can change our skin, our nails, our scalp. And what most folks, for those of you, of course, treating patients know is people want to get back to looking and feeling like themselves. So those workshops are designed to help them get there. And here you can just see some quick before and after photos of patients that have gone through that workshop. This is just a quick snapshot of our factory. The town of La Roche-Posay is about 1,000 people year round, and we're proud to be the largest employer between the clinic, which treats up to 30,000 patients a year, and our factory. We're able to run 3 shifts there, so products are produced around the clock. And with that, I'm going to turn it over to Dr. Ho. I'll be back at the very end just to tell you a little bit about the products that have been studied to show that they are beneficial and safe on cancer patients. And these will be the products that you will be receiving for attending tonight's webinar. Thanks so much.
Hey, hi everyone. My name is Alice Ho. I have an MD as well as an MBA in healthcare administration, and I'm a radiation oncologist who focuses on the treatment of breast cancer patients. And currently I serve as the co-director of the Breast Clinical Research Unit at Duke University. So thank you very much for being here today. And what I'd like to do is, first of all, start off with a polling question. Which of the following factors increase the risk of developing moderate to severe radiation dermatitis? So please select one of the following: the total dose of radiation, mucosal tissues that are being irradiated, skin folds, particle therapy such as proton therapy or superficial electron therapy, or all of the above. Okay, so I see that 94% of people selected all of the above, which is correct. So I think the rest of this talk is going to be very easy for you, but hopefully enjoyable. So let's go to the next slide. So radiation therapy, as you all know, this is a treatment modality that has been treating cancer for more than 100 years. 1.8 million patients are diagnosed with cancer in 2002, and at least 50% of them will be treated with radiation therapy. And among those who are treated with radiation therapy, up to 90% will develop radiation dermatitis, which inevitably affects quality of life. And when the skin reaction is severe enough, it can actually result in a treatment interruption, which can potentially affect clinical or oncologic outcomes. So the goal is to really minimize the frequency and severity of these reactions, not just for quality of life, but also for treatment efficacy for the cancer. Well, what is the biologic basis for radiation therapy? Radiation works by damaging the DNA of cells and causing double-strand breaks, and it destroys their ability to reproduce because cancer cells are inherently dysfunctional in their ability to repair after an injury or an insult like radiation or chemotherapy. However, both normal and cancer cells can be affected by radiation, but the difference is that cancer cells, as I said, they have an impaired ability to repair, which leads to cell death. However, normal tissues such as the skin usually can repair back to its and restore its normal function. It's important to keep in mind that all tissues have a tolerance level, and beyond a maximum dose, different organs have different doses that they can repair the damage from. So for instance, the spinal cord is very sensitive to radiation, as are lymphocytes. Skin, prostate, and other organs have a higher tolerance that they can endure with the radiation. The way radiation is typically delivered is through a linear accelerator. External beam radiation is the most common type of radiation. It's when the beams are delivered with this linear accelerator. And there's also a less common form of internal radiation called brachytherapy. And you can either put catheters or seeds that are with radioactive sources that are placed into the tumor or right near the tumor. The way we measure any units of radiation is called a gray or a rad. And so 1 gray is equal to 100 centigrade. So you may find in patient notes from oncologists or radiation oncologists that the patient received X centigrade or gray. So that's a very common terminology. There are various sources of ionizing radiation. I would say 95% of ionizing radiation are something called photon beams, and these consist of either gamma rays or X-rays. Some of you may have heard of something called particle therapy. There's something called protons or electrons, and in fact, there are many centers in the US as well as Europe and Asia that have proton centers in particular. And this is a very special type of radiation because it is incredibly targeted, and it really prevents unwanted radiation from going to surrounding structures. But the cost of that, it has a very high entry and exit dose. And so these type of particle therapies tend to deliver higher doses to the skin, and you will see that in the form of a very brisk skin reaction. Now, there are various markings that are placed during radiation. So I don't know if many of you see patients while they are actively receiving radiation. I would imagine many of you see them after radiation, but you may see little tattoos or marks that are really there in order to align the patient accurately for radiation. And I'm just mentioning this so you know what the purpose of those markings are. There are some centers that use ink marks with stickers on top of it, which can be problematic because as the skin desquamates in response to the radiation, sometimes the stickers can aggravate that. But the good news is that many centers are now switching over to technologies where they can align the patients without stickers or tattoos by employing technologies that rely on surface imaging mapping. So as I mentioned before, the challenge of radiation dermatitis is that it can definitely impact quality of life in a very negative way during as well as after radiation. And the problem is that there is really no standardized way to manage radiation dermatitis among radiation oncology providers. And that really leads to a very under-recognized and unmet clinical need when it comes to diagnosing as well as treating radiation dermatitis. I have been very privileged to work at academic centers where I have had access to very skillful and knowledgeable oncodermatologists, but usually what is the case is that there's very little collaboration between radiation oncologists and dermatologists regarding the management of cutaneous toxicities from radiation. And so it's really important providers, whether they're dermatologists or radiation oncologists, they need to uniformly educate patients on the importance of skincare and really implement a skincare regimen that everyone agrees upon that can help prevent, delay, or manage skin changes early so that we can really minimize the incidence of more long-term effects. So many patients refer to radiation dermatitis or skin changes as a burn, but it's important to understand that it's not actually a burn, and there are clear differences in etiology, the time to the reaction, the skin layers that are affected, and the sequence of the damage between a radiation skin reaction and a burn injury. And I think you all know this, but you can read it for yourself on this table. The bigger difference with the radiation skin reaction is it's really a cumulative type of thing, and with breast radiation and most types of radiation, you only really start seeing changes by the end of the second week or the beginning of the third week of radiation. And of course, that really varies depending on a number of factors. So what are risk factors for developing radiation dermatitis? Well, there are patient-specific ones as well as treatment or disease-specific. And I will go over some of these very briefly. Older age, obesity, malnutrition or smoking, if there's a history of connective tissue disorders, especially those with active scleroderma, which is actually a contraindication to giving radiation, other kind of autoimmune disorders, HIV, or chronic defects in skin integrity, as well as some individuals with very rare single nucleotide polymorphisms. Those aren't things that are normally picked up in a workup of a patient, but has been shown in research to be a risk factor for developing radiation dermatitis. And then there are the treatment or disease-specific therapies, such as concurrent systemic therapies or immunotherapy. The type of radiation modality I mentioned, that protons and electrons, which are particle therapies, have greater skin reaction than photon therapy. The cumulative dose of radiation, the individual fraction size or the chunk of radiation, as I like to say to patients. Sometimes radiation oncologists will boost or give a little extra dose of radiation to a smaller area, or they'll use something called a bolus, which is a thick material that's tissue equivalent, and they place it on the skin deliberately to increase the dose to the skin. And that happens often when patients have inflammatory breast cancer or other types of cancers where the lymphatics of the skin are involved, and you deliberately want to increase that dose to the skin. The beam energy also counts. The higher the energy, the more penetrating. So actually, the more penetrating, the less dose to the skin. And anytime there's a skin fold or a pannus or somewhere in the groin or organs with mucous membranes, those are all areas where radiation dermatitis can affect that region. So I had mentioned the course of time in terms of the skin changes, but usually one starts with an edema and then some erythema that's mild to moderate, and that can turn into usually hyperpigmentation and then desquamation that starts with dry desquamation and then moist desquamation where that desquamated skin begins to weep. And then this is very rarely seen with the type of radiation we deliver these days, but necrosis is a very severe but uncommon side effect. And then when we get into really late changes because of these acute changes, these include telangiectasias as well as fibroses. This is a slide that is a courtesy of Dr. Leventhal, and these are just photographs with other chronic dermatologic complications of radiation. You can see some radiation enhancement and recall where the portal of the radiation is reactive, usually with another type of stressor or treatment. There are definitely radiation-associated neoplasms that tends to be a number of years out from treatment. There is radiation-induced morphia and other radiation-triggered type of dermatoses, which I will leave to Dr. Leventhal to discuss. The common areas where moderate to severe radiation dermatitis can develop, I had mentioned some of this in earlier slides, but you can see examples where there's mucositis in the oral cavity with head and neck cancer. You can see that there's dry desquamation in the neck, desquamation that's often moist in the vulva area, and you can see a very bad case of desquamation in the anus. I will say that that is a picture of a patient treated with much older radiation techniques that we don't use these days, so something to that severity is pretty uncommon. Nevertheless, given the mucosal surfaces, that is certainly something that can happen. So I'd mentioned these radiation techniques that deliberately increase the skin dose. I'd mentioned the bolus. You can see that kind of jello-like material. It's a tissue equivalent material that comes in various thicknesses. The thicker the bolus, the higher the dose of radiation that the skin will see. And as I mentioned, this is used in inflammatory breast cancer or anytime there's tumor that's kind of ulcerating through the skin and you really want to target the skin. A boost, as I mentioned, is when a smaller area of an organ gets an extra dose of radiation. And oftentimes you can give that with very superficial types of radiation, such as electrons. And again, particle therapy includes electrons or proton therapy, which is very valued because it spares unwanted low-dose radiation to surrounding organs, but it comes at the cost of higher skin doses. And now, even with modern proton therapy, radiation oncologists are actually able to control the skin dose a little bit more than older proton therapy techniques. When a patient gets proton therapy, you can see on the left, she has a very brisk skin reaction with erythema that's much more marked compared to a similar patient who would be treated with photon external beam therapy. But as I said, with the newer IMPT or scanning proton techniques, we can actually adjust the skin dose. But a question that we are working out is, what is the optimal dose that the skin should get so that a patient does not see recurrence at the skin? And that's very much a question that we are still trying to find the answer to. And I do want to show you that despite some of these acute skin reactions, many patients, such as this patient on the left, 3 years after patients, they can still have excellent cosmesis, whereas you see the patient on the right who definitely has some telangiectasia that's evident in the medial aspect of the reconstructed breast, as well as some contracture of that implant. We use this current grading system for radiation dermatitis. This is the CTCAE or RTOG grade from 0 to 3 to 4. I would say that it's really hard to grade between 1 to 2, but fairly obvious when we get to the higher grades. And you can see that in breast cancer, the majority of patients do have grades 1 to 2. Whereas the sites with the mucosal areas that I showed you, such as the vulva or head and neck, or those are areas that have more severe radiation dermatitis grades. So I treat breast cancer, so I wanted to just point out to you that the patients who are most at risk for developing radiation dermatitis are those who've had mastectomy, and that's because the breast tissue has been removed with a mastectomy, and what the target is the skin and the underlying lymphatics. So we are deliberately targeting the skin when a patient undergoes a mastectomy, whereas if a patient undergoes a lumpectomy, we are just trying to treat the entire breast and not necessarily just the skin. Mastectomy scars are also often boosted with extra radiation because it's been shown that there's a very high risk of recurrence at the scar area. And we often use that bolus material that I showed you in order to deliberately increase dose to the skin. And many patients have implant reconstructions, and skin breakdown in that situation could potentially lead to infection and implant loss. So it's even more important in patients who've had reconstruction that we really try to minimize the risk of desquamation. Now, plant, petroleum, tourmaline, panthenol-containing products are not really considered standard for prevention of radiation dermatitis in breast cancer patients. Nevertheless, I noticed that they are still frequently used and asked about. And I would say that topical steroid efficacy, which has been reported in head and neck patients as well as breast cancer patients with intact breasts receiving whole breast radiation, have been reported. Now, this is a randomized trial of a moderate strength steroid called mometasone furoate, which has been shown to reduce high-grade acute radiation dermatitis, specifically in breast cancer patients who have received a mastectomy. And so Dr. Mario Lacouture and I undertook this study when I was at Memorial Sloan Kettering, really to see whether the use of mometasone would improve or reduce the incidence of moderate to severe radiation dermatitis in those breast cancer patients who are receiving post-mastectomy radiation. So it was a randomized design, 143 patients who are randomized 1-to-1 to either standard of care, and in this case we call that Eucerin, and the experimental agent was mometasone furoate. And this was a double-blinded trial. So the provider and the patient, neither one of them knew which cream they were assigned to. And the primary outcome was either grade 2 acute radiation dermatitis with moist desquamation or any grade 3 dermatitis. And for secondary outcomes, we looked at the maximum grade of acute radiation dermatitis, the time to occurrence, and the quality of life as assessed with the SkinDex-16 questionnaire. And what we found was that those patients who received mometasone furoate, you can see in the left with the blue bar representing mometasone, had a statistically significant reduction in the incidence of moist desquamation from 66.7% in those patients receiving Eucerin to 43.8% in those patients receiving mometasone furoate. And when you look across the board in the different types of grade, you can see that there was a higher incidence of grade 2 erythema for whatever reason in the mometasone furoate arm, but in the grade 2 and 3 moist desquamation, with grade 2 or grade 3, there was a reduction in acute radiation dermatitis with the use of mometasone furoate. And when we looked at specific sites, the supraclavicular region, as well as the axilla and the chest wall are all sites that are at risk, but mometasone really appeared to improve the risk of developing moist desquamation, specifically in the chest wall. And when we did a multivariate analysis, the type of cream, in this case being mometasone furoate, that was statistically significant in terms of reducing the risk of moist desquamation. And this V110 of the skin that's outlined in red on the right, that really represents the high hotspots or doses of radiation. Again, making the point that the actual dose of radiation or the hot areas radiation also very much make an impact. So how do radiation oncologists generally advise patients on skincare regimens during radiation? First, we recommend that sunscreen is used on any sun-exposed regions. We recommend that moisturization of the irradiated region daily with non-perfumed, non-irritative emollients should be performed. And although there's no standard on what emollients are commonly recommended, Aquaphor is quite popular and commonly recommended. Other popular products are Biafine, CeraVe, Jeans Cream, Emu Oil, Calendula Cream, and aloe vera containing creams are quite popular because they're considered more holistic. And although steroid ointments have been variably adopted into the clinic, mostly due to fear of skin thinning and systemic absorption, I have been encouraged to see that since the publication of the study and since the publication of these guidelines that radiation oncologists and dermatologists have created together, more and more radiation oncologists are adopting steroid therapy into their skincare regimens for patients receiving breast radiation. And there is some interest in some non-adherent wound dressings and barrier films as well. And I will show you that by demonstrating that there's an ongoing cooperative group trial called the Alliance A221803 Mepitel trial, where breast cancer patients who are receiving post-mastectomy radiation or are very large-breasted are randomized to either receive standard skincare or application of this barrier film called Mepitel during radiation. And in the end, CTCAE radiation-induced skin toxicities will be compared to see whether the film reduced those skin toxicities. And although it's really great that there's interest in reducing skin toxicities from radiation, just some practical issues with this have been just the cost of the film, as well as the increased nursing that is required to apply this film. Nevertheless, this will add really important information and data that we don't currently have. So it's really great that people are doing this type of work. So once a patient develops severe radiation oncologist, a question that comes up is how do radiation oncologists manage it? And I have to say this is where it really gets incredibly varied, and there really needs to be some more work done in terms of uniformizing these recommendations. I tend to use Silvadene ointment. Once a patient develops the moderate to severe radiation, of course, I tell patients to stop using steroids on that area, and we usually switch to Silvadene ointment. When there's fungating lesions, Flagyl spray is added, and then nursing often can apply Xeroform gauze, occlusive dressings, and pain certainly, it's important to manage pain. That's very important because pain prevents healing, and pain also prevents patients from being compliant with some of our recommendations. But I would say the most important thing to do, hopefully before patients even reach the stage where it becomes moderate to severe, is really to refer to an oncodermatologist as soon as possible. And so because I do this frequently, when I can sense that there is something special about this patient, or she is deliberately or he is deliberately receiving a type of radiation where radiation dermatitis is likely to occur, I tend to send them to the dermatologist very early on. And so that is a practice that we need to encourage and continue to practice. So in conclusion, radiation dermatitis is a common side effect of cancer treatment that invariably affects many patients. And despite data from randomized trials, such as the mometasone trial, there is variable but increasing uptake in utilizing evidence-driven approaches that can prevent and manage radiation dermatitis. And I would say a challenge is the inconsistent communication between radiation oncologists and dermatologists, but we are trying to change that type of paradigm by just communicating more and doing more studies and research together. There is lack of knowledge and lack of interdisciplinary coordination that we are aiming to fix, and that's really what is feeding misinformation and lack of knowledge. But we do need better data from well-designed interdisciplinary clinical trials in order to change practice. And of course, we are all very interested in biomarkers that will help identify those patients who are at highest risk for developing radiation dermatitis. So this just demonstrates how really, as you all know, all of our treatments and our intents are very patient-centered, and around the patients are all these various providers who help take care of the patient, and really we need to communicate with one another to really communicate or let each other know when skin changes are taking place in the patient and interventions can be initiated. So with that, I would like to introduce my wonderful colleague, Dr. Jonathan Leventhal, who was a dermatologist. He's actually the director of the oncodermatology program at the Yale School of Medicine. He is an associate professor in New Haven, Connecticut, and I will let Jonathan take it away.
Thank you so much, Alice. So it's a real pleasure to be here today and speak alongside my esteemed colleague and to discuss an algorithm on the prevention and management of acute radiation dermatitis. So dermatologists have found themselves playing an increasingly important role, partnering up with medical oncologists and radiation oncologists as part of the whole team taking care of cancer patients. By managing cutaneous adverse events, which are very common in these patients, we can improve their quality of life. We can also help improve clinical outcomes and their ability to stay on treatments, especially in severe presentations. I think one of our important roles is to also identify and promptly manage any severe cutaneous reactions, including those that are life-threatening. And if unknown, we have the ability to obtain histopathology through biopsies and treat in a very specific way, targeting our therapy to the specific toxicity. So we'll begin with the second polling question. What types of cutaneous adverse events may occur from radiation therapy? So select one of the following: erythema and skin pain, dry desquamation, moist desquamation, skin ulceration, or all of the above. So the vast majority of you chose the correct answer, all of the above and we'll review clinical presentations and grading criteria of these manifestations. Okay, just gonna move forward. Good. So the outline of today's talk is I'm going to review the U.S. Cutaneous Oncodermatology Management Group and some of the projects that we've been working on to help improve the quality of care of cancer patients in a multidisciplinary fashion. Dr. Alice Ho discussed the challenges of acute radiation dermatitis at length. I'm going to try to really focus on an algorithm set forth by various experts in medical oncology, radiation oncology, and oncodermatology on best ways to prevent and manage acute radiation dermatitis. So the U.S. Cutaneous Oncodermatology Management Group was developed to bring together a panel of experts who work at cancer centers to help improve the quality of life of cancer patients and survivors for preventing and managing cutaneous adverse events. So our first project was aimed to come up with an algorithm that would be helpful to provide recommendations on skincare and over-the-counter measures for cancer patients. Our second project, which I'm going to present today, is an algorithm on treating acute radiation dermatitis. And next we'll be working on cutaneous toxicities from immunotherapy, followed by targeted therapy and other systemic chemotherapies. So working at a cancer center and seeing patients with cutaneous adverse events, they can occur from really all types of anti-cancer modalities. And all of these toxicities can really impact patients' quality of life. Here are some examples of patients that I might see in a given clinic: alopecia from chemotherapy, acneiform eruptions from targeted therapy, hand-foot skin reactions from targeted therapy, or hand-foot syndrome from traditional chemotherapy. Nail toxicities are super common, including paronychia from targeted therapy and chemo. And finally, radiation toxicities, especially higher grade acute radiation dermatitis, as pictured here. And managing these cutaneous adverse events are so important for so many different components of the overall care of patients, namely quality of life, which is a big one. So looking at studies on quality of life metrics, patients most frequently report dermatologic adverse events from their cancer treatments as carrying a negative impact. And what's interesting is studies have shown that they're often worse than initially perceived. And I think this underscores the importance of educating patients even prior to their initiation of anti-cancer therapy on what to expect and how to best manage these reactions promptly. I think that the vast majority of toxicities that occur from cancer therapies in general can be treated and patients are able to remain on their therapy. However, in severe presentations, patients might often have a drug holiday, a dose reduction, and in the most severe cases, discontinuation of their cancer treatment. And studies that have looked at patients with breast cancer found that 60% found that alopecia as the most traumatic side effect from their therapy, and almost 10% of women with breast cancer would decline chemotherapy because of fear of this. So these toxicities really have a profound impact on their patients. And I think another important concept is that these side effects aren't just impacting the functional and physical domains of quality of life, but they really have a major impact on psychological well-being. One study found that patients undergoing radiation therapy found that they had quite an emotional burden from radiation dermatitis, including their impact on their body image, their emotional well-being. They'd feel signs and symptoms of depression or anxiety. And so this is really important. And studies in survivors have even found that scars from oncological surgeries can lead to psychological problems in up to 50% of survivors years later. So not just cancer patients, but even survivors who have stigmata of their cancer treatments from cutaneous toxicities can be impacted. And then looking at women who underwent cancer treatment, one study found that a third dermatologic adverse events as the most important during their treatment that contributed negatively towards the health-related quality of life. So let's talk about radiation. This study from the Journal of American Academy of Dermatology prospectively looked at patients who underwent radiation therapy with breast, head and neck, and anal cancer. And they conducted quality of life metrics using the Skindex 16, which is a validated quality of life survey. And what they found is that radiation resulted in negative impact on quality of life in various domains, most notably symptoms such as stinging, irritation, burning, pruritus, but also the emotional domain as well as functionality. And there was a clear correlation with the severity of radiation dermatitis and the impact on quality of life. So with that in mind, the U.S. Cutaneous Oncodermatology Group, which included some of the authors listed here, sought to put together an algorithm to help cancer patients and any healthcare providers managing patients with cancer. The first project was on gentle skincare measures. And I'll just provide a brief highlight of what the algorithm looks like. It basically takes the cancer patient's journey all throughout the treatment from prior to starting therapy, which includes patient education about skincare, irritants, and sun exposure, as well as preventive skincare with cleansing, moisturizing, and protecting their skin, to surveillance for skin adverse events, particularly the ones that are quite common, such as xerosis, dermatitis, or pruritus, and then the general approach towards low-grade reactions in which patients continue their treatment and are managed as needed by dermatologists, to those that are more severe and require urgent evaluation. I think, as I mentioned earlier, that one of the important roles of any cancer provider is to recognize those red flag signs and symptoms such as fever, skin pain, mucosal involvement, or significant lab abnormalities. So we're going to focus the remainder of the talk on our second project, which was published as a supplement in the Journal of Drugs and Dermatology. And this was the multidisciplinary guided algorithm for preventing and managing acute radiation dermatitis. So this algorithm focused on acute radiation dermatitis as opposed to the many changes that can occur as chronic radiation changes. And a recent Delphi study was published in the British Journal of Dermatology by my colleague at Memorial Sloan Kettering, Anthony Rossi, to discuss an algorithmic approach and treatment recommendations for chronic radiation dermatitis. We're going to focus on acute radiation dermatitis today. But first, it's important to have an understanding of the grading criteria, because like all cutaneous toxicities of cancer therapy, the severity of presentation will really dictate the management. So let's take a look at the clinical correlates. So for grade 1, you see faint erythema or dry desquamation. Patients with grade 2 present with moderate to brisk erythema and edema, and they'll start to develop moist desquamation in the skin folds, as you can see over here. Once the moist desquamation is more confluent and spreads outside the folds, that's considered grade 3. These patients often have bleeding induced by minor trauma. And as Dr. Alice Ho mentioned earlier, grade 4 radiation dermatitis, which is fortunately quite uncommon, results from full skin necrosis and full thickness ulceration. These patients often have secondary infection and require surgical intervention, whether it's debridement of necrotic tissue or skin grafting. I wanted to briefly show some images of chronic radiation changes, which are not going to be addressed in our algorithm, but I think they're important. These can develop months to years later, and we see a lot of patients at the clinic with this, and they can manifest as telangiectasias and dyspigmentation to contracture and fibrosis. This is particularly debilitating when it involves the breast or the head and neck area. So the aim of our algorithm was to improve patient comfort, reduce inflammation, and promote healing of the skin caused by radiation dermatitis. And while there does exist several guidelines on the management of acute radiation dermatitis, this algorithm provides a more uniform approach that takes that really begins prior to treatment with prevention all throughout the treatment. And so we used the modified Delphi approach, where we first conducted definitions of the project and aims, conducted a comprehensive literature review, then we got together to meet and formulate an algorithm, and then had consensus through blinded votes to finally reach our final algorithm, which was published in the Journal of Drugs and Dermatology. So a literature review was conducted by dermatologists and physician scientists, looking at literature in the English language from 2010 to 2021, and the articles were then analyzed based on the grade of clinical evidence using the AAD guidelines. So grade A, for instance, has the highest quality of evidence randomized controlled trials compared to grade C. And then they were further categorized as grades 1 to 4, depending on reviewer consensus, where grade 1 had the highest quality. So these are the search results, which included multiple clinical studies, guidelines, and review articles. And this is the finished product, which we're going to review. As you can see here, this algorithm has multiple components, from pre-radiation patient education to preventive therapy during day 1 of radiation to managing the radiation dermatitis based on the severity. So we'll dissect it part by part. So the first part, patient education, is very important and included avoidance of skin irritants and sun exposure, and giving patient information about cleansers and moisturizers to use, as well as photo protection. I think some of the important highlights of patient education is to really engage in open and frequent communication, educating patients on what to expect, really allowing them to have contacts that are accessible to address toxicities when they occur in a timely fashion. And I think another important component is to provide this information in something that's tangible, whether it's a pamphlet or a sheet or digital website to go to, because patients are often unable to retain all the information that they receive when being diagnosed with a cancer or before they undergo treatment. So I found that these educational resources to be very helpful. And here's an example of some of them that exist, including MSK has on their website cutaneous adverse events and the various toxicities, ASCO, as well as cancer.net and cancer.gov. So these are the expert guided recommendations for skin cleansers and moisturizers. I think dermatologists in general are very familiar with this. Gentle cleansers, avoiding harsh fragrance cleansers. I think an important area to educate patients who are undergoing radiation is to really try to avoid trauma and friction. So loose fit clothing, you can certainly wash the skin gently, but you want to avoid using a washcloth directly on skin that's denuded. And then regarding the moisturizers, similarly, gentle cleansers, avoidance of irritants, including fragrances and perfumes. I think the vehicle is really important. So for instance, ointments and creams are far superior as emollients compared to those vehicles that have a higher alcohol content, such as solutions, which can be quite stinging on irradiated skin. And this was the results of a literature review on which ingredients were found to be useful in treating radiation dermatitis versus which were not. And this chart simplifies it a little bit over here. And aloe vera, for instance, which is an ingredient in many topicals that are used, was actually found not to benefit patients with acute radiation dermatitis, whereas those that had ingredients such as hyaluronic acid or topical steroids were beneficial. Another area of interest is whether gentle skincare and use of emollients alone can help improve radiation dermatitis outside of medical therapy. In this study, prospectively looked at patients who were given a regimen that consisted of 2 types of cleansers, a moisturizer, healing balm, and an SPF, and categorized over 200 patients prospectively as either low users versus heavy users. And what they found is that those who were heavy users had a delayed onset to the development of radiation toxicity. And when you looked at the opinion of the investigating physicians, they found that those who were heavy users, the physicians felt that the benefit was far superior. And the main takeaways of this study was that these products were tolerated on irradiated skin. They delay the appearance of early skin reactions, and heavy users showed significantly less severe toxicity to radiation, even with these emollients and photoprotection. And then finally, with patient education, photoprotection, I'm not going to spend too long discussing all the different types of sunscreens, but basically sunscreens can be divided into physical blockers and chemical blockers. Chemical blockers include those that block UVA versus UVB. Most currently available sunscreens aim for coverage of both UVA and UVB, And I really think counseling patients on the use of sunscreens, protective clothing, and sun avoidance is really important. So now the patients are beginning radiation day 1, and based on the randomized controlled trial that Dr. Alice Ho mentioned earlier, we recommend the use of mid-potency topical steroids such as mometasone or triamcinolone twice daily throughout the radiation treatment and continuing it 2 weeks after treatment, in addition to using gentle cleansers and moisturizers. Should radiation dermatitis develop, as it does in the vast majority of patients, our approach towards it depends on the grade. So for those who have dry desquamation, we use low to mid potency topical steroids. For those with moist desquamation, I'll discuss this further, using topical antimicrobials. And for those who develop grade 4 ulceration and necrosis, well, they require surgical and wound intervention. So let's take a look at putting it all together on the algorithm. So if a patient presents with grade 1 faint erythema and dry desquamation, or grade 2, which is brisk erythema, but without moist desquamation, these are the kinds of patients that we recommend continuing their radiation therapy and monitoring while continuing topical corticosteroids. Should a patient develop patchy moist desquamation in the folds or more confluent moist desquamation, that's where bacterial cultures are recommended. Studies have found that oftentimes secondary bacterial infection can play a role in the pathogenesis of acute radiation dermatitis. We recommend the use of topical antimicrobials, which includes topical mupirocin or silver sulfadiazine cream. Biologic dressings can be helpful, and you can continue the topical corticosteroids outside of the moist desquamated area, but really use the antimicrobial topicals within the areas of moist desquamation. Pain control is incredibly important. NSAIDs might help with the inflammation, while opiates are often needed for more severe presentations, and certainly consultation with dermatology is recommended. For patients who present with grade 4 radiation dermatitis, obviously the radiation therapy will be put on hold, and the patient would seek urgent care, urgent medical care. I might add that should a patient with grade 3 radiation dermatitis improve, the patient could be restarted on radiation therapy depending on a multidisciplinary communication with the radiation oncology and medical oncology team. So in summary, from Dr. Alice Ho's talk and my talk today, you learned that acute radiation dermatitis occurs in most patients during radiation therapy and frequently impacts health-related quality of life. The prevention and management of radiation dermatitis in a multidisciplinary fashion using this evidence-based approach will hopefully improve patient outcomes. And I really wanted to emphasize the importance of patient education and frequent communication with the patient and the entire oncology team to optimize clinical outcomes. So thank you for your time and for listening.
Thanks so much, doctors. Great talk. And we're going to be making sure that we send over a copy of those publications, those peer-reviewed publications, along with the products. La Roche-Posay products have been studied extensively on cancer patients to ensure that they can help offset some of the treatment side effects, help repair their skin barrier, help also to rebalance with some of the microbiome if that's in an unbalanced state, and also just to make the skin feel better. So we have great science on our products to ensure that they are safe and effective. And the products that have been tested for care include our Lipicar Syndet. It's a gentle wash that does foam, our Lipicar Balm Triple Repair Moisturizing Cream, and our Cicaplast Balm. And then what we're also going to be including for you to try out is our Thermal Spring Water, which is the water format in all of our products, as well as 2 of our sunscreens, one of which is that mineral sunscreen. Just a reminder, if you do have questions, throw them into the chat because we do have a few minutes and the doctors would be happy to answer any questions related to tonight's talk.
And we do have a couple of questions from our audience. The first question is, how do you decide when to stop radiation therapy if a patient develops acute radiation dermatitis?
Okay, so I'm assuming that question is for me. I think you have to consider, first of all, how aggressive is this patient's cancer? If it's something like head and neck cancer, which is very proliferative, even taking a little bit of a break can actually have very big impact on the oncologic outcomes. But then on the other end of the spectrum, you may be treating a patient with a very early stage favorable risk breast cancer. So you first, think about what it is you're trying to treat. And then you think about where along the treatment is this happening. So if the patient has maybe 1 to 2 more fractions to go, a radiation oncologist might try to push the patient through and then really, and whereas if she has maybe a week more to go, there's consideration for stopping, taking a treatment break, reevaluating once the skin is healed, and then starting. So it depends on the type of cancer, the area being treated, how much more is left, and really just really managing the pain and having a plan for how to heal the skin before you really make that call.
Another question, do you find that patients treated with topical therapies while undergoing RT and develop minimal acute skin changes are less likely to develop skin changes long-term after RT has been completed?
Not sure who that's directed to. I think that's me again. So yes, for sure. I think that if you minimize acute changes, you're much less likely to see chronic changes. I will say that, I mean, the skin is so resilient. I have seen patients with really bad dermatitis where 1 month later, 2 months later, they look really well again. So I don't think the converse is always true. It's only when radiation acute changes get so severe, for instance, grade 4, that can lead to late effects. But yes, to answer that question, there's benefit in preventing these acute changes because I do think that reduces chronic changes such as fibrosis and telangiectasias for sure.
How do you best integrate oncodermatology care in an oncology or radiation oncology practice?
Yeah, that's a really good question. I think if you work at an academic center like Alice and I do, many cancer centers have dermatologists that are really integrated into the oncologic care, which is great. It really fosters not just multidisciplinary care, but collaborations on research and guidelines and preventive strategies. I think if you're an oncologist or radiation oncologist in the community, it's really important to find a dermatologist that's willing to partner with you and see these patients. I think access is a huge issue in dermatology, and if someone were to develop a severe reaction either to radiation or to chemotherapy, they can't just wait 6 months to be evaluated. So I think that's really important. And if you are a dermatologist interested in this in the community, I think seeking out oncologists and radiation oncologists and giving educational lectures to advanced practice providers, nursing care teams can really make such a big difference. So that's what I recommend.
What are your thoughts on the oh, sorry. Dr.
Oh, no, that's okay. I was just going to say, I think there's a very important component of also educating your nurses, regardless of whether you're in an academic or community setting, on the importance of prophylaxis and having uniform guidelines. And I find that nurses, regardless of whatever setting you practice in, are very interested in working to prevent dermatitis in the radiation patients.
What are your thoughts on the common myth of worsening bolus effect if patients apply a normal application of lotion prior to radiation?
So there actually have been studies that have been performed that have looked at the thickness of a cream that's applied and what kind of bolus-like effect it has on the skin. Most of us, even when we put on a lot of cream, you don't put on enough to have any kind of consistent thickness to create any kind of bolus effect. So it's been quite minimal. Patients often say to me, is it okay for me to go into radiation when I've applied the emollient right before? And as long as it doesn't interfere with their skin markings, and it shouldn't if a patient is getting tattooed or not even relying on tattoos and using some of these technologies I talked about, a normal application of cream is certainly not going to cause a bolus effect.
We still recommend aloe vera as needed and calendula cream BID. Do you have any good studies that I could reference to change this practice? It seems that we should be getting rid of our aloe vera recommendation.
Yeah, read the JDD supplement. We have the tables that I illustrated on useful topicals versus not useful topicals and their cited references.
What common cleansers would you recommend?
So I wouldn't recommend any specific one brand, but I would basically go with gentle cleansers that are, you know, simple over-the-counter ones that are fragrance-free, that are non-irritating. They don't have extra ingredients that make it smell or feel nice on the skin. Those can actually be more irritating. Sometimes the simplest ones, ones that are ointment vehicles, are really nice. I would stay away from vehicles that are solutions because they have a higher alcohol content and can certainly sting. I'd stay away from topical sprays as well for that reason.
Are there any studies characterizing alterations of the skin surface microbiome in the radiation-treated area?
That's a really good question. And Dr. Beth McClellan at Einstein has really pioneered this work on the importance of the microbiome in acute radiation dermatitis. And what her group found is that there actually seems to be a pathogenic role for Staph aureus, and measures that are taken to actually to reduce colonization with Staph aureus with the use of topical mupirocin and I believe also topical antiseptics can actually reduce the severity of acute radiation dermatitis. And I think it's data like that that prompted experts in the field to recommend the use of topical antimicrobials such as mupirocin or silver sulfadiazine for moist desquamation. And I think her paper was published in JAMA Oncology just recently.
And what was fascinating also about that paper is that intervention not only helped those who were colonized with staph, but those who are staph negative as well. So that's very interesting.
Do you recommend mometasone non-fluorinated over triamcinolone?
So personally, I think that they're both mid-potency topical steroids, and depending on whichever one is preferred by insurance is the one I'd recommend.
I agree with that. Our study happened to use mometasone, but of course, if you can't get approval for mometasone, which I actually have not seen that frequently, then the other one would be just fine.
Any role for topical exosomes for anti-inflammatory effect? Would there be a concern of stimulation of cancer cells?
Not sure about that one. What about you?
Are fungal infections a common problem in advanced radiation dermatitis and skin folds, and how do you treat for this?
That's a great question because it's a very common scenario, especially in large-breasted individuals, in the inframammary fold, and in areas with hot weather, though everyone is hot right now. Well, first thing we tell them is we have to kind of counter a common myth that cornstarch is good for treating that area, and we tell patients to not do that. And then I just recommend a gentle cleanser, pat it dry, and I recommend a topical antifungal.
Yeah, I would tend to agree. I think the major problem that occurs is intertrigo, and most cases of intertrigo are actually an irritant contact dermatitis, so dermatitis rather than candidal overgrowth. I think if there's clinical evidence of candida infection, such as satellite papules and pustules, then certainly treating it, you can obtain a superficial wound culture that would for sure let you know if there was candidal superinfection. But I tend to find that the severe cases are more likely to actually have just bad dermatitis and Staph aureus as opposed to candidal.
How do you respond to patients who want all natural products?
I don't think you can stop them. I think something that I've seen more increasingly is the use of CBD oils or CBD-based emollients to counteract any inflammation. So I certainly, of course, I have my regimen that I recommend, but there are always some patients who are going to want to do their own thing, and you know, their friends tell them this worked for me, so give this a try. And so you know, you have to be consistent, but you also have to accept that there are patients who aren't always going to follow your instructions. And so I think that a start is us providers being uniform on what should be standard of care, but also I think getting into some of the patient communities with some consumer advocates, disseminating the right information is really important.
And one final question, do atopic eczema prone patients get more radiation dermatitis?
I'm sorry, could you repeat that question?
So do eczema patients are more prone to get radiation dermatitis?
That's a really good question. So I've seen patients who have underlying dermatoses, whether it's eczema or psoriasis or bullous pemphigoid or pemphigus flare in the irradiation field for sure. I think the studies will probably show that there is a correlation. I'd say the answer is yes. I think if a patient has an underlying dermatosis like lichen planus, psoriasis, eczema, you want to optimize it to make sure it's under control and really follow these patients closely and manage them aggressively. What do you think, Dr. Hope?
I completely agree. That's really when you want to have your dermatologist following the patient. I'd prefer that the patient see the dermatologist before he or she starts radiation.
Well, that's all the time that we have left together, but we would like to thank our speakers for excellent presentations with practical tips and tools to help patients, oncology patients with radiation dermatitis. We'd like to thank, where is he, Dr. Mr. Steele from La Roche-Posay, there he is, for making this educational event possible for everybody. And we'd like to thank you all for joining us this evening. Good night, everybody.
Night.
One.